Seema. Dr. Seema Bhargava is currently working as a chairperson, Department of Biochemistry, Sir Gangaram Hospital. And she's also former chairperson of Kaho Diagnostic Division. And she's past president of ACBI, Association of Clinical Biochemists of India. And she's also consultant for International Federation of Clinical Chemistry, Evidence-Based Laboratory Medicine Committee. She's also a member of IFCC Task Force for Laboratory Medicine Practice Guidelines. And today's topic, she will be presenting on latest guidelines for cardiac biomarkers, applying the evidence. Over to you, Dr. Seema.
Thank you. Thank you, Dr. Mamta. And thank you for making that brief. That was very important. So good evening, everyone. And it is my very great pleasure to be on this platform. It is a unique platform where clinicians and diagnosticians come together, diagnosticians from every field come together and talk about one organ system or one disease and try to try to educate everyone what is the latest. And in the process, we do educate each other also. So thank you to the clinicians for joining us today. We're very happy to have you. So my topic, as Mamta already said, is the latest guidelines for cardiac biomarkers, applying the evidence. And with a heart that is so sick, we definitely want it to become bouncing and good. So therefore, I will start my presentation with talking about the prevalence, the global as well as Indian scenario. Then I'll talk about cardiac, what they are and who has made them. Then I'll talk about the components of the lipid profile, mechanisms of atherosclerosis to some extent, and recommendations of testing. And also, what are the newer biomarker targets? I'll put it all together in one so that we don't miss a beat. And that's the theme for this year's cardiology. As you can see here, this is the scenario not only for India, but it is for all other, sorry, my bad. So this is when you talk about cardiovascular disease, we are talking about the global burden, and we're talking about the disability of life years that have been caused by this. And these are the region-wise. This is a 2022 data given by, oh no, again. This is given by Minash et al. And what is important here is it's a huge burden. It may not be the maximum in the world, but it is a huge burden. And then lower down, we have the metabolic risk. If you highlight it, you can see that in this high LDL cholesterol and a high body mass index are all very, very high. And you can see that the pink and the green, which denote your ischemic heart disease and cerebrovascular disease, are the highest amongst all other risks. Next, please. So when you talk about heart disease and stroke statistics again, every 34 seconds, someone dies of a heart attack. And every 3 minutes and 17 seconds, someone dies of a stroke. Next, please. This is what I was highlighting. In 2017, the data showed that 17.7 million people died from cardiovascular disease. Next, please. And 2022 data, sorry, go back, please. You went further too fast. 2022 data showed that it is 19.8 million people. Next, please. As we said, next. Global prevalence is 7,750 per 100,000. And what the Indian, next, please. The Indian scenario shows that the death toll due to cardiovascular disease, next please, in 2016 was 15.2 and it has almost doubled to 28.1 in 2020. Next please. The cardiovascular disease in Indians is very different. It is called the Asian Indian paradox. What they say is that the risk of cardiovascular disease is the least in the Japanese amongst Asians. It is 3 times as much as the Japanese and Chinese. It is 6 times as much in white Americans, but in Indians, it is 20 times as much. And the mean age of the affected population is 5 to 10 years less in Indians than any other population. Amongst the less conventional risk factors, we don't have many. There are more of conventional risk factors in the other populations. Then the incidence of cardiovascular disease in patients under 50 years of age is 12 to 16%, which is 3 times as much as in other Western populations. And all of you know this young man. He died suddenly of a heart attack a few years ago. He was less than 50. He was a vegan. They say that non-veg diet causes this. And as you can see, he definitely is non-obese. Next, please. So with these thoughts, we let us enumerate the few important cardiac biomarkers. And you have the acute, which are HS, high sensitivity troponins, the CKMB mass fraction, and NT-proBNP, that is the N-terminal of proBNP, and the chronic ones that are the cholesterols, all the cholesterols, and the triglycerides and apolipoproteins and lipoprotein A. Together, they all form the lipid profile. There is also high sensitivity CRP has also been used, and homocysteine also should be used. Next, please. Thank you. Next. So if you talk about creatinine phosphokinase, all of us know CPK was discovered in the 60s, and the disadvantage was that it is not specific to the myocardium, and therefore it was not able to help us identify cardiac problems. And then the isoenzymes were also discovered in the 70s, and in them, the disadvantage was, and in this, there was the cardiac specific isoenzyme MB, that is CKMB, CK isoenzyme 2. But this also had a disadvantage in that the isoenzymes are unstable and interconvertible, and they are released into the circulation in many other conditions, including AMI. So again, you cannot diagnose a case of acute myocardial infarction with this. The extent of elevation also does not reflect the extent of myocardial damage, which is very important because all these enzymes are, whatever was done for investigating was meant to identify what is the burden in that patient, what should we do, what does he need immediately. So if we cannot identify how much the burden is, we can't do that. So the mass, then in the 80s, we had a new measurement or new estimation method came up for estimating the mass of the MB fraction that was released. And because when the myocardium loses its CKMB molecule, that molecule can get deactivated enzymatically. Its enzymatic activity can decrease, but the mass doesn't change. So therefore, this was a stable marker, and it was not interconvertible with the others because it is very specific. So this gave a better interpretation of the myocardial cells being destroyed. And therefore, this method also had a better predictive value in negative as well as positive than total CPK and CKMB activity due to the better methodologies. And therefore, I suggest please do not order CKMB activity. Next, please. Please order instead CKMB mass. And all you need to do for that is take a sample in a plain vial. Next, please. When we talk about other biomarkers, again, NT-proBNP is also an acute as well as chronic marker. So as you can see, the cardiac myocyte, it releases its cytoplasmic granules are released and they contain proBNP. And in the action of with the action of current, proBNP is converted to equimolecular concentrations of a biologically active BNP and a biologically inactive amino terminal of proBNP, which is also known as NT-proBNP. What was the problem with the BNP per se, the biologically active form, is that again, it is an unstable molecule, while as NT-proBNP was amenable to methods of estimation. But what we have to remember when we interpret these assays, either BNP or NT-proBNP, is that they change with age, they increase with age, and they are dependent on renal function because they are excreted by the kidneys. Body mass index also makes a difference. They will increase in atrial fibrillation and also other non-cardiac conditions like anemia, cirrhosis, pulmonary edema. Next, please. And the diagnosis of heart failure is actually NT-proBNP is the most useful in the diagnosis of heart failure, especially in excluding it when a patient comes to you for AMI. But I will not talk about that or the triage because Dr. Behel will be talking about it. And it is also used for risk stratification. Sample again, a plain or an EDTA vial may be used for sample collection, but it has to be processed within 4 hours. Please remember that for NT-proBNP. Troponins came in the late 90s, and they have three fractions, the C, the I, and the T. The C is attached to calcium, whereas the I and the T are the ones that get released and are easily amenable to estimation. And trop I and trop T are specific to the myocardium. But currently, troponin I is preferred as evidence shows that it has a better correlation with cardiac damage. Also, newer methodologies have come where the limit of detection has decreased and therefore the sensitivity and the specificity has increased. As you can see, earlier we could detect values only up to less than 100 picograms per ml, while as now we could just 100 was the limit that we could detect, while as today in our HS tropi, what we do is we are able to detect 0.15 up to 0.15. Can I have the next one, please? And therefore, this sample for this can be either, again, EDTA or plain vial, but it has to be processed immediately because the fourth global task force on myocardial infarction says that the turnaround time for for troponins has to be 1 hour. We have to give the report within an hour. So then how can we do that unless we process it immediately? CRP and HSCRP. So C-reactive protein was discovered in 1930s, and their methodologies were also discovered then. And in 1943, its association with cardiac disease was, it was known as an inflammatory marker, but its association with cardiac disease came to be known in 1943. And only in the 1990s were the assays developed. But what is the difference between CRP and HSCRP? The protein is the same. Please, there is no confusion about that. Or many of us have a lot of confusion about this, diagnosticians and clinicians alike. So let me reiterate, the protein is the same. One was discovered in 1930 and the high sensitivity was in 1943 because its association with cardiac disease. Its clinical significance of CRP, of the CRP estimation, is in inflammatory conditions, whereas HSCRP is used for atherosclerotic risk stratification. Methods of estimation for both can be ELISA, immunoturbidimetry, or nephrometry. While methods for C-reactive protein usually have a low sensitivity as compared to HSCRP, and that is equivalent to about 1 milligram per liter. But for this, for HSCRP, our sensitivity is up to 0.15 milligram per liter. So it is 10 times more sensitive. The biological reference interval used for interpreting this assay is for CRP, which is what we use as an inflammatory marker, the total CRP. In normal individuals, you expect it to be less than 5. 5 to 10 is considered inflammation. And if there's severe systemic inflammation, it should be more than 10. For cardiac risk stratification, those normal groups have to be divided into less than equal to 1, 1 to 3, and more than 3. And in that, the low risk is less than or equal to 1. 1 to 3 is moderate risk, and more than 3 constitutes high risk. But they're all normal individuals, healthy individuals. There's another molecule which is less talked of and quite ignored, according to me. It was discovered by Vincent de Vinoy in 1932, and this is homocysteine. It's a sulfur-containing amino acid, but it was first associated with atherosclerosis by Kilmer McKinley in 1968 and in 1971. Two of pathologists. These were pathologists who identified its correlation with intense vascular atherosclerotic disease, one in adults and one in children. And for the first time, estimation was started in India by our lab because we thought it was very important for our population. And why did we think so? So the mean homocysteine in our North Indian population, as per one of the studies we conducted, was 7.76% higher than in the worldwide population. The odds ratio for coronary artery disease conferred by homocysteine is 4.33, and that conferred by the conventional biomarkers is only 1.1 to 1.8. In addition, it is a modifiable risk factor, and the modification is very simple. You have to just administer folate and vitamin B12 in the right doses, 1500 milligram and 5 milligram. What is another thing that was very important is that it has no threshold, a threshold effect, and its pathogenicity increases threefold when you increase its value from the population mean of 10.78 to the upper limit of the BRI, which is just 4 milligrams more, and that is 15 milligrams, micrograms, micromoles per liter. How does it cause this risk? Why does it cause so much of risk? So the various mechanisms, next please. Various mechanisms are given here, and the consequences are many. There is increase in lipid peroxidation, increased migration and depletion of these oxidant lipids. There is increased there is decrease in the endothelial relaxation and through decreased production of nitric oxides. Platelet adhesion is increased, and therefore there is more thrombus formation, and there is an increased proliferation of smooth muscle cells in the substantia propria. Through all these methods, it causes cardiovascular and cerebrovascular thrombosis and thrombosis of the peripheral vessels also, atherothrombosis, not just thrombosis. And it is also implicated in cognitive impairment through different mechanisms. And therefore, I feel that homocysteine should be estimated during every cardiac episode so that the simple adjuvant therapy of vitamins B12 and folate can be administered and some amount of risk can be reduced. They cannot replace anything else. Coming to the lipid profile, and so what are the components? You have total cholesterol, but what is it made of? It's made of HDL cholesterol, which has ApoA1 attached to it, LDL cholesterol, which has ApoB attached to it, and VLDL cholesterol. In addition, we also have triglycerides and lipoprotein A, which has apoprotein B as well as apolipoprotein A. So when we talk about LDL, how does it cause vascular atherothrombosis? So first of all, there has to be some injury to the endothelium. Because of that, the VCAM1 is released from the endothelial cells, and this helps the macrophages, monocytes to migrate to the subendothelial layer where they produce MCP1 and CCR2. This causes them to become scavengers of lipid. And meanwhile, the smaller dense lipid LDL molecules, which can pass through because of VCAM, which can pass through the endothelial layer to the subendothelium, these are all taken up by these scavenger monocytes, and they form foam cells and die. And this lipid core is left in the subendothelial layer and forms the base of your atheroma. At the same time, we have constant oxidation also of LDL, which makes it even more easy to be picked up by the scavenger monocytes. Also, we have collagen that is altered because of that one of the parts of the release of these cytokines causes an alteration in the collagen, and therefore it becomes less stretchable in the substantia propria. And next, please. And the smooth muscle cells, back, please. And the smooth muscle cells, as I already have told you, they also proliferate. So this is the whole embargo. So you have an endothelium, you have a subendothelial mechanism, then you have the muscle, the media in the muscle with the media, the smooth muscle cells in the media, and then you have the substantia propria where the collagen. At all four levels, there is impaction of these atheromas, and one causes a decrease in the lumen of your vessel and the other causes the base of the atheroma. Next, please. LDL is well known for its atherosclerotic functions. And as I said, it has an ApoB100 attached to it. And this ApoB100 actually is what is recognized by the LDL receptor on the hepatocyte. Next, please. And as you can see, once it gets attached, LDL gets disintegrated, and therefore ApoB is very important. Now, PCSK9 is released by the endoplasmic reticulum, and it attaches to the LDL receptors. Next, please. And therefore blocks them for action by ApoB 100. And therefore it causes an increase, back please, it causes an increase in serum LDL. And that is why PCSK9 inhibitors have also been used to reduce circulating LDLCs, the low density lipoproteins. Next, please. HDL is a very nice molecule. It is the good cholesterol, as we call it. It has antioxidant properties. It has anti-inflammatory properties. It has antithrombotic and antiplatelet and C protein activation properties. It is profibrinolytic. It enhances reverse cholesterol transport also. And through all these mechanisms, it has an anti-atherothrombotic effect. Next, please. So its role has been very widely studied in therapeutics also, because they say if HDL is such a good molecule, let us increase the HDL. And but the problem is that it is genetically determined, and the only way that they have found HDL increases in lifestyle modifications is by walking a lot and by taking foods very high in vitamin C. You have to have the vitamin C has to be of the order of 2 grams per day for it to actually increase. But a molecule, but one of the studies, Eliminate, which was a global clinical trial, studied the effect. So what happens is there is a CETP deficiency, and in this causes a cholesterol ester transfer protein. When there is a deficiency of this, HDL increases normally when there's a genetic deficiency. So to simulate that, the Illuminate trial decided to use a CETP inhibitor. And unfortunately, it did not work well, and it had to be abandoned in the phase 3 because the inhibitor that was used, that is torcetrapib, was caused high cardiovascular disease and increased the deaths also. Then there was another second phase, which was called Accelerate, where they used delsatrapib and evacetrapib. But these were also found to be ineffective in that they increased HDL, but they did not reduce cardiac events. Then the final one was Reveal, which used anacetrapib. And this is the randomized evaluation of effects of anacetrapib through lipid modification. This caused a significant decrease in major cardiac events, and the this decrease, though significant, was only moderate, and this was considered to be due to more due to a decrease in the non-HDL fraction of cholesterol rather than an increase in the HDL. So it is often used alone or with statins, and the only side effect is that it causes a slight increase in blood pressure, but a slight decrease in diabetes mellitus, which is quite a good thing. So having known the effects of LDL and HDL, we have a CVD risk assessment, which is given by the international guidelines. But as you can see, they talk only about LDL and HDL. But what about the other components? Next, please. What about the other components? So let's see what is the scenario in our country. We did this study in about 2000, where we estimated the lipid profiles in 483 subjects and 257 controls and 226 coronary artery disease subjects. As you can see, there was not much difference between the controls and the subject. And this is because everyone had a high cholesterol, everyone had a low HDL, high LDL, high triglyceride, and lipoprotein was also higher. And this is what constitutes the atherogenic milieu, which is found typically more in Indians, in other Asians also, but maximum in Indians. Next, please. We thought that lifestyle modifications will change the scenario. But when a few years ago, we during the course of another study, we also estimated the lipid profiles of 4,130 subjects. And again, it was the same atherogenic milieu in controls as well as in patients of coronary artery disease. Next, please. So then, with this also in mind and with a few other things in mind, the Cardiology Society of India decided to bring up clinical practice guidelines. This is based on 20 years of data, patient data that they had. All of them sat together, took them 2 to 3 years to collate that data, to put it together, and to come to a certain conclusion what should be done for lipid management in Indian patients. As you can see, part of their study was showing what is the prevalence of all these: hypercholesterolemia, hypertriglyceridemia, low HDL, next please, and high LDL. But I would like to talk about the low HDL and high LDL, hypertriglyceridemia. Next, please. It was so shocking that in more than 80% of the regions of India, a low HDL was observed in, please, more than 60% of the population. Next, please. And in more than 70% of the regions of India, high triglyceride was seen in more than 25% of the population. So both these constitute quite a disease burden. So a number of challenges. In this guideline, that was the first author being Dr. Sani, who is the head of our who's the chairman of our cardiology department in Sir Gangaram Hospital. He and his team found that there are a number of challenges to following the international guidelines for lipid management. And these include premature occurrence of major coronary artery disease risk factors, a large burden of premature CAD, a high prevalence of raised total LDL and non-HDL cholesterol, a high prevalence of familial hypercholesterolemia. This also came from their database of 20 years of patients' data, and a high prevalence of hypertriglyceridemia in association with diabetes and metabolic syndrome. And last of all, the high prevalence of elevated LPA. So we've talked about how LDL and HDL work, but let us talk about how triglycerides function. So triglycerides, whether they are absorbed by the intestine or whether, sorry, please go back, or whether they are synthesized by the liver endogenously, they form either VLDL particles or chylomicrons, both of which undergo lipolysis and give remnant lipoproteins, which are highly atherogenic. These are all the small, dense lipoproteins which flow through your system and which enter your subendothelial layer, get deposited there, and cause an atheroma formation. Next, please. And it has been this has been used. Sorry, could you go back, please? This fact has been used by addressing cholestyramines, giving cholestyramines as therapy. It has been used as a as a triglyceride lowering agent. So what ApoB100 and lipoprotein A? So ApoB100 is the one molecule, molecule that is present on the LDL particle, and that is the one that is recognized by your LDL receptor on the hepatocyte. Next, please. And as you can see, all the small, dense particles contain ApoB100. And these are all there given this. And what is important, therefore, please next. What is important, therefore, is that one must measure ApoB100. Sorry, please go back. And it is an integral structural component of all these atherogenic lipoproteins, and the mutations result in non-recognition of the LDL molecule by the hepatocyte. Next, please. If you talk about LPA, it has an LDL core with an apolipoprotein B100 as well as an apolipoprotein A attached to it. So it has two parts. One is the LDL per se along with ApoB100, and the other is the apoprotein A. Now, it causes atherosclerosis. How does it do so? As you see that it can normally be recognized, the ApoB100 is recognized by LDLR, and the LDL's part of the LPA gets disintegrated in the liver. Next, please. But if there are ApoB100 polymorphisms, then it is not recognized, and then LPA also increases. How is it associated with the, next please? How is it associated with the atherothrombosis? So normally the thromboplastin A has a small plasminogen binding site onto which plasminogen binds next. And this causes an increase, or rather a decrease in clotting. And therefore, if there is any clot, it gets dissolved and it maintains a normal balance. And to help it maintain the normal balance, we also have a plasminogen activator inhibitor. There is a molecule that activates the plasminogen, and there is an inhibitor for it. So therefore, that inhibits, and so your all your mechanisms of clotting and dissolution of the clot is at a balance. And then the LDL core has this apoprotein A, which competes with plasminogen on the plasminogen binding site on the thromboplastin A, and therefore it stops the effect of the reduced clotting. So therefore there is more clotting. So therefore it causes thrombosis. Next, please. And at the same time, the core itself, it stimulates the plasminogen activator inhibitor, and thereby it therefore further reduces plasminogen and further reduces the positive effect of plasminogen in reducing clotting, and therefore there is further atherothrombosis. So we already know that the LDL core will cause direct atherosclerosis, while as this part of it was the mechanism for its causing thrombosis. The LPA gene is found on chromosome 6, and the most common polymorphisms seen are the K4 polymorphisms, and there are all of these variety of polymorphisms. Next, please. In our population, what we saw is that amongst our patients of cardiovascular disease, we had a higher lipoprotein A, but we didn't have a much lower lipoprotein A in our controls. That was also 28, and 30 is supposed to be the upper limit of the biological reference interval. However, back please, back please. However, the lipoprotein A, any value above 50 is considered very atherogenic. So there is a ongoing study which has almost culminated. They are just putting together the data, and this used pelacarsen. It used its function as a lipoprotein A reducing action, and therefore they wanted to see, does pelacarsen reduce lipoprotein A and thereby reduce cardiovascular events also? And because it reduces LPA by about 92%. So therefore, that is what they wanted to see. And so far, the results have shown, yes, it is helpful, and therefore it might be used. Going back to this slide is that we are in the internationally, all of this is known, all these studies are there, and yet they talk about only LDL and HDL. Next, please. So what are the current trends of testing? What should be the time of sampling? Please remember, fasting or no fasting, you can take a lipid profile. And I'll tell you why. First of all, there is no variation in HDL, and there is a very minor variation in LDL or LPA. But total cholesterol, there is a 15% diurnal variation and the same percent of variation with non-fasting or fasting. It doesn't make a difference, and you can discount that. The only molecule that is highly variable in fasting and non-fasting, the non-fasting, is triglycerides. And because of that, the recommendation is that a fasting sample is not required for lipid profiles. I repeat that a fasting sample is not required. Internationally, it is accepted that it is not required. Unless, please, back, please, back, please. Unless the triglyceride is high, that is, it is above 400 milligrams per deciliter, or there is a family history of hypertriglyceridemia or even familial hypercholesterolemia. In both these instances, you will take a fasting sample. Next, please. How do you do LDL? Traditionally, earlier we had all these equations, and they got they got evolved and evolved and evolved into very, very complicated equations. But the gold standard, next please, is still direct measurement of LDL. Next, please. Non-HDL versus individual components of the lipid profile. Now, why we are talking about non-HDL, and I'm talking to you about these things because this non-HDL has been very strongly highlighted in these latest guidelines that have been given by Cardiology Society of India. And they say that non-HDL includes all the atherogenic components. And it is easily calculated from two estimations. So wherever there is a dearth of availability of tests and things like that, you can do a total cholesterol and an HDL and you get your non-HDL. Another reason is that there is a subset of patients who have high LDL particles numbers, but an increased level of small dense LDL. And therefore, they come as a total normal LDL value, but the non-HDL is high. So it helps us to identify this subset of patient. And the accuracy of cardiovascular risk prediction by LDL is also reduced due to the increased incidence of metabolic syndrome. And all currently available lipid lowering agents target one or the other of the non-HDL components. Next, please. So what should we do? Should we do total cholesterol and HDL for diagnosis? No, that's not enough. LDL-C and LPA, because those are the atherogenic ones, not enough. What you need to do is all the components at one time for diagnosis for the first time. You should especially include LPA and ApoB100 wherever it is available, especially where there is a high suspicion of cardiovascular disease or there is a family history of familial hypercholesterolemia. Next, please. For follow-up, what should you do? Again, you have the dilemma, we need to do only this much or no, only this much. But no, you must do the whole lipid profile again. And also, you must make sure that, next please, whatever is being targeted by the management, by whatever the molecules are being targeted by therapy, have to be estimated at each follow-up. Next, please. And non-HDL-C also must be estimated every time. Next, please. So now our report has to be it has to be helpful for the patient. It has to be helpful for the patient and for the treating clinician who is sitting there. And some people are sitting in the far reach outs of our country where they don't have access to the latest diagnostic modules and everything. They have to know, what does this report mean? So what our report has, it has three components. The first component is what every lipid profile report has. It has the analyte given, it has the levels given, and it has the biological reference interval. That is now part one of our report. The second part is assigning risk category to an individual. This every patient can also do himself, and the clinician treating can also do himself. Can also do it for him. So this tells you that if you have no cardiovascular risk factors, you are a low risk patient. Moderate risk is when any one cardiovascular risk factor. Now, what are those factors? Smoking, tobacco, hypertension, diabetes, dyslipidemia, central obesity, family history of younger heart attacks. That constitutes moderate risk. If you have diabetes mellitus with one or more risk factors or hypertension with one or more risk factors, that becomes high risk. And if there is clinical evidence of blocked arteries, that becomes very high risk. Any elevated LPA above 50 milligrams comes under very high risk. Next, please. The third part of our report is, what are the goals? If I am a low risk person, what are the goals I have to achieve in my lipid profile? If I am a moderate risk person, what are the goals I have to achieve? Next, please. So as you can see, for triglycerides and lipoprotein A, the rule, and for HDL, the rule is the same. For HDL, it is males have to maintain more than 40, females more than 50. Triglycerides have to be maintained less than 150 and lipoprotein less than 50. But when it comes to LDL and non-HDL-C, in the low and moderate risk category, they have to maintain their LDL at less than 100 and their non-HDL at less than 130. For those who are described as high-risk subjects, they have to maintain their LDL at less than 70 and non-HDL at less than 100. And those who have a very high risk have to maintain LDL less than 55 and non-HDL less than 85. Next, please. Also, we want to talk about ApoB, and ApoB in low and moderate can be maintained under 100, but in case of high risk and very high risk, it should be 80 and less than 80 and less than 65 respectively. To tell you about a few targets, newer molecules that have been targeted by therapy. One, I've already talked about PCSK9. Next, please. You also have ATP citrate lyase, which is the which helps in production of acetyl coenzyme A, which is the substrate for acetyl co-carboxylase and increases cholesterol synthesis. If you give an inhibitor, that has also ACL inhibitors are also being used. Ezetimibe is also being used because it decreases the absorption of cholesterol and therefore decreases delivery of cholesterol to the liver. Then cholesterol, normally it is converted to bile acids, and 85% is reabsorbed from the gut. And when there is a reduction in this enzyme, 7-alpha hydroxylase, it is further reduced. There is more and more, the bile acids are not formed, so all of it gets reabsorbed. Now, cholestyramine causes an increased excretion, 10 times increased excretion of bile acids, and that is why it is used, and therefore it increases the conversion of cholesterol to bile acids. Next, please. Inclisiran is another molecule that has been recently targeted. It is comprised of two strands, a guide strand and a passenger strand. The passenger strand is attached to a GalNAc, which enables targeted delivery of inclisiran to the hepatocyte. And the guide strand mimics the body's natural process of RNA interference by complementary base pairing to selectively target PCSK9 production. So it also reduces PCSK9 and it also attaches to the hepatocytes and increases the LDL modifications. And therefore, it increases hepatic uptake of LDL-C and decreases the circulating. Now, how do you use it? It is recommended that it should be given in a twice-yearly dose as an injection, and it is used as a complement only to maximum statin dose. Only when a maximum statin dose fails to bring down the LDL to the desired level, only then should you use this. It is effective and sustained. It causes an effective and sustained reduction in LDL of up to 98%. And all these things have been accepted. All these findings of our Cardiology Society of India and these guidelines given by the Cardiology Society with the evidence that they have given have been accepted and have been appreciated by the European Society of Cardiology and the European Atherosclerotic Society. Next, please. So to conclude, I'd like to say that guidelines for testing include and interpretation and management of lipid profile should be in context of cardiovascular disease are constantly evolving and they may differ for different populations. For initial diagnosis, the complete lipid profile along with LPA and preferably ApoB is the best. For follow-up, all parameters that are being targeted should be there. All the lipid profile parameters should also be there, and the non-HDL must be seen. Next, please. And establishing the level of risk, especially by estimation of lipid profile, must be on basis of the most recent India-specific guidelines with respect to age, gender, family history, and population. And when the lipid profile is normal and there is a family history of hypercholesterolemia or hypertriglyceridemia, timely identification of risk is very, very important. Thank you very much. I hope I didn't take too much time. I might have. I'm really sorry for that, but thank you very much. And over to you, and I'll just stop sharing.
I have stopped. Thank you so much, Dr. Seema, for taking us through to the all cardiac biomarkers and all the available possible treatment options, as well as the correct reporting for the Indian population.